We are live.
So, a very good evening, everybody. So, on behalf of the AIOS, I'm Dr. Nupur Goel. I'll be coordinating the session. So, we've had a wonderful sessions, of the International Ophthalmic Conclave by AIOS, and it's been wonderful. Since last evening, you've been seeing some wonderful sessions, and this session is pediatric corneal diseases. And we have some esteemed, distinguished faculty with us, as the chairpersons and moderators, and some wonderful talks ahead. So without further much ado, let me just hand over the podium to Dr. Muralidhar Ramappa, who's the moderator for the session, a wonderful pediatric corneal surgeon. And I've been lucky to have, trained under Sir during my fellowship at LVP. Over to you, Dr. Muralidhar, to moderate the session.
Thank you, Dr. Nupur, for the kind words. And I'm blessed to have some of the best faculty today. And I'll be showing the introductory slides. Give me a second. So myself, Muralidhar, I work at LV Prasad Eye Institute, currently head of services for a cornea, and my primary focus is pediatric corneal diseases. And we have a very well-known, renowned professor, Professor Radhika Tandon. She's also chief and a professor of ophthalmology at Harpi Center, AIIMS, New Delhi. And Madam has a wealth of experience in dealing with not only pediatric cornea, including the adult cornea, cataract, and she'll bring in a huge value to the today's discussion forum. And we have a world-renowned pediatric ophthalmologist, Professor Arif Khan. He is division head and chief of pediatric ophthalmology and the neuro-ophthalmology department at Cleveland Clinic of Abu Dhabi. And Sir primarily focuses on a developmental biology of the eye and also is one of the leading experts in ocular genetics. So Sir again add a huge value when it comes to our discussion. And we have a senior faculty member, Dr. Meena Lakshmipati. Currently, she works at Shankar Nethralaya. She has huge experience in dealing with not only pediatric corneal condition and also microbial infection. She also heads, the hospital infection control at Shankar Nethralaya. Welcome, madam. And we have a world-renowned pediatric glaucoma specialist, Dr. Mandal, and he's been with the LV Prasad Eye Institute for over 35 years. And he brings in a huge, value when it comes to anterior segment developmental abnormality and tackling, various conditions. And we have an associate professor and a very dynamic ophthalmologist from PGI. She not only focuses on adult cornea refractive surgery, and she has a keen interest in a pediatric corneal disease. Welcome, Parul. And we have a young, dynamic surgeon, Shalini from Arvind Institute at Coimbatore, and she'll be bringing pediatric corneal experience as well. And Rashmi is a young, dynamic cornea specialist. She recently finished her long-term fellowship at LV Prasad Eye Institute. She'll be bringing in and showcasing a very unusual case scenario. Apart from that, we have an expert panelist, Revati Madam. She is the most accomplished ophthalmologist, well senior, and she has enormous experience when it comes to cornea. And she's also part of the several clinical trials like SCUT and MUT trials, which are world-renowned, and they gave a lot of insight in managing particularly the corneal infections worldwide. Welcome you, madam. And Anshuman Verma is a molecular biologist. He works under my lab, and he's been a very big strength when it comes to clinical-genetic correlations. Currently, he's helping with me precision-based medicine. We are attempting a gene therapy in some of the corneal dystrophies. Welcome, Anshuman.
Good evening, everyone.
Yeah, without further ado, and we get started with, the Radhika Tandon, madam. She would be delivering a keynote lecture. Over to you, madam.
Good evening, everyone. I'll just share my slides. Okay. So I'm going to cover the congenital cloudy cornea, pediatric corneal disorders, unraveling the code. I hope the slides are visible.
Yes, madam. Visible. You can go ahead.
So, over the years, with the advances in ocular research and interventional approaches, some of the key changes over, say, the past 15 years has been the improved understanding about the importance of molecular genetics. In fact, the entire classification of the corneal dystrophies has taken a sea change after recognizing that it is the genetics which holds the code. So, unlike our previous anatomical based classification, now it is including the genetic information, and one has now understood that there is a lot of overlap in terms of the same gene can have various phenotypes and so on. So, I just want to focus that what we used to consider as very simple, that this is what it looks like and this is what it is. But when you look at the genetics, it may not always be that simple, and there's a lot more work which needs to be done. And I'll illustrate a few examples during my talk. Now, there is no doubt that we do have unique populations in India, and in India itself, there's a lot of variations in the kind of disorders we see in different parts of the country. Focusing on pediatric disorders, if you look at CHED per se, we know that the SLC4A11 gene is associated with the disease, and though a lot of work has already been done and published, we felt that there was a need to characterize the pattern of disease and the genetic profile of patients visiting our clinic. So we were able to get some funding because unfortunately the tests are expensive and patients cannot afford them. So we were able to convince a research agency to give us some funding. And it was not only restricted to CHED, it included other corneal dystrophies, but within that whole project, we had 35 subjects from 28 families who were diagnosed with CHED, and we obviously screened them for the known mutation. Relatively, compared to the other dystrophies, it had a relatively low occurrence, and there was a high degree of consanguinity among the patients' families. Here, the consanguinity was between cousins rather than vertical. So it was families where they were cousins and they had got married and then they had children. However, to our surprise, though we had a very, very clear-cut clinical concept that the disease was CHED, and we expected that we should get the gene in every single case, but we didn't. So there was no mutation identified in 21 patients. And plus, we did come across some novel mutations as well. So it again sort of illustrated that there is an existence of genetic heterogeneity, there is some overlap, and we really were puzzled as to why we didn't get the gene in every patient. So this is the study which was, the results of the study have been published, and this was completed several years ago. I'm sorry, my phone, I should have put it on off. I'm so sorry. So that's one part of the story I wanted to share. The other thing is we also found that when we have a little baby coming with a cloudy cornea, or they come with, sort of an abnormal cornea, we thought that it should be fairly straightforward to differentiate between the various disorders. However, that again is not so true. So talking about developmental abnormalities of the cornea, we even very, very experienced specialists sometimes would be challenged. It may be because of the disease severity variation. It may be because the patients come at different stages of the disease, or it may simply be that the diseases are too complex. So when we look at the developmental abnormalities of the cornea, we have the congenital opacities, including Peters, CHED. Of course, we have other things like microcornea, aniridia, sclerocornea, and the ectasias. But out of these, which are the disease disorders which can have a combination of features? Like, for example, they can have associated raised intraocular pressure. They may actually have glaucoma and so on. And we looked at whether we could help make things a little bit simpler. If we are getting confused, then what would one consider in peripheral places where they may not have that much of experience? So a multidisciplinary approach. and explored the importance of anterior segment imaging. Here again, we do understand that these equipments are very expensive. They are tertiary care and they're not going to be available in the periphery. But we thought that with all the knowledge and experience we have and with the equipment, can we put this all together and come out with some kind of a simplified guideline so that these cases can be more easily diagnosed at peripheral places. Of course, they will have to refer them to a tertiary care center. But in the interim, we would always like that everybody should be empowered, have the satisfaction that this is their patient and they were able to make a right diagnosis. So this is what we explored. So we said, can artificial intelligence help? And for this, there was a thesis done by Dr. Ananya, and we looked at the various characterization. And apart from images, we also put in data such as the age of onset, family history, laterality, symmetry, symptoms, and other corneal features. And CHED, PCG, primary congenital glaucoma, and Peters. These were the ones. And again, somebody not familiar with complex cases may think, these are totally different diseases. Why are you getting confused? But it does happen because you can have glaucoma, and also there can be a lot of variations in the presentation. And so these were the various characteristics that we looked at. So as far as this project goes, we had 42 patients, 82 eyes, and I would like to again express the idea was can we end up with some kind of a clue as to which is the feature which would be the key identifying feature between them. So between CHED, Peters, and primary congenital glaucoma, there was a significant difference between the three diseases in terms of age at presentation. So the CHED presented much later as compared to the other two. The other thing was demographic data again. There was significant difference between as I mentioned before, that there was a later presentation of CHED. This possibly indicates that the extent of the opacity tends to be a little bit more subtle. It's more like a blue as compared to the white that you get with Peters, and a little more symptomatic, maybe tearing or enlargement of the eyes in the case of primary congenital glaucoma. And then looking at the corneal status, the nature of the opacity, here again, there was a significant difference between the corneal opacities when diagnosed by a trained cornea consultant and a fellow. Now, looking at the corneal diameter, this was clearly greater in cases of primary congenital glaucoma. So that's another parameter. So if people are not used to thinking in this way, the idea is to say that, it's good to look at this, but it's not to say that a patient who has a normal corneal diameter and is Peters may not have raised intraocular pressure. But yes, if you want to characterize it into the different compartments, then you have to pay attention to these details. So there was significant difference in the corneal diameter. Here again, both horizontal and vertical. Then coming to the UBM. So the UBM parameters were extremely helpful, and this was highly significantly good in differentiating Peters from CHED and primary congenital glaucoma. In addition, highly significantly iris thickness and ciliary body thickness. Now here, I'm not saying that we're going to expect people to do a UBM and measure the iris thickness, but with this precision, and if this AI tool is taking this into account, and if later, when we have more patients, we can correlate through the AI model, that it can somehow, correlate easier with just a simple picture with what it is. So the more precision we put in, the better we may be able to get an AI tool which may be practically useful. Now, looking at the genetic analysis, we found that in this particular cohort, the mutation was present in all the cases of CHED. It was present in 4 patients of Peters and 5 patients of primary congenital glaucoma. And this is the spectrum of the genes that were identified. So in this particular small cohort, there was no significant difference in terms of the presence and absence of mutations. But look at the fact that there was an absence of mutations. So here, again, it's a genetic disease. There is a gene responsible. Supposedly, the gene is identified, but we're not able to find it. So the geneticists understand it, but as a clinician, I don't. And we need to, and it's a little bit disheartening and a little bit frustrating. Now, looking at the other features that we found, there were some unique patients we had, and for example, we had 5 patients of so-called type 1 Peters where no mutation was detected. Similarly, type 2, and there was there were patients with only the 5 patients where we did find the CYP1B1 mutation and the FOXC1 mutation. So therefore, we know childhood is a very critical time of life. We have a baby who is coming, and these things may be a little esoteric. Ultimately, you do have to treat the patient, you do have to take care of the vision and the follow-up and so on. The more we understand, we may be able to give a better prognosis, we may be able to give a better sense of satisfaction to the family that they know what their child has. But you can see IOCT is very, very useful. So IOCT images, when we incorporate into AI tool, is very, very helpful, 100% accurate in differentiating the disorders. And earlier, unilateral opacities, we used to hesitate to operate, thinking that is very poor prognosis and amblyopia and all that. But with better eye banking, more pediatric corneas being harvested, better quality surgery and instruments and follow-up, we're able to give even unilateral opacities a very successful outcome after keratoplasty. So this is another patient who had been operated, patient of ASTA, had in fact a graft rejection as soon as 3 months after the surgery, which was successfully reversed because mother was very motivated and would rush to the hospital anytime there was a problem. And as you can see, there was a young donor. And this is a patient of CHED. One eye, she had a penetrating keratoplasty, and then the other eye, she has had a DSEC. However, she has come back recently. Now she's a lot older. She's 12 years old. She has come back with graft rejection related failure, and she's going for a resurgery. And again, we're exploring whether there is anything further to explain why some patients have more rejections compared to others. This is another patient who has microphthalmos in one eye and a congenital corneal opacity in the other eye with a successful surgery, successful outcome after optical PK. And this child was operated at 11 months old. And initially, my philosophy was operate on one eye, and then you just work with that eye, and then you avoid touching the other eye because second surgery may induce a rejection in the initial graft. However, this baby was operated 11 months, came back at the age of 9 years, and she has undergone a keratoplasty in the other eye as well. And with very, very careful monitoring of the treatment, etc., both grafts have remained clear, and she has not had any rejection at all. So why some children get the rejection, some children don't get the rejection, despite being very careful with their post-op follow-up, etc., that's again something which we are trying to look at. So basically, in a nutshell, diagnosis is definitely clinical. Surgery has to be done, but these are all the additional things that we are trying to unravel on the way. Tomography, corneal biomechanics can be looked at in the future to the children who've grown up, and similarly, in vivo confocal microscopy is also an option. So thank you very much for your attention.
Thank you, ma'am, for a very informative talk. I believe, I agree with you. There are huge overlap when it comes to, anterior segment corneal conditions. At times, even an expert will have a challenging, whether it is a CHCD, PCG, or we are dealing with PPCD, or even, sometimes, Peters anomaly. I think, imaging, the last decade or so, particularly swept source imaging has changed the entire landscape, how we diagnose and deal with that. And I agree with you, ma'am. We attempted several times molecular screening. I was surprised. This is a family of CHCD. How come we don't find the mutation? Anshuman, do you want to come here and give a one-line answer? Why do we fail to get a genetic basis in some small subset of cases?
Yeah, so the theoretical answer for this is that the mutation may be in some other region of the gene, like promoter region or deep intronic regions, or the area of the region which we didn't cover during sequencing. And the second reason may be the other genes involved, but that is again always a matter of investigations. And with today's facility, if the gene is involved, that can be discovered easily having a familial cases. So all these areas, sometimes they are not explored or sometimes they are ignored. But these are the possible regions when we don't find a mutation in the case.
Now, one of the reasons for this one, molecular screening at times, it's not completely black and white. And even that interpretation, Dr. Arif Khan, would you throw some light on how do we interpret a genetic analysis, particularly in a context where you have a confusing diagnosis, a overlapping clinical spectrum?
Yes, actually, let me first say that I really enjoyed that presentation. And I just have a few comments, including the answer to what you said. First of all, in my experience, the SLC4A11 is so specific for CHED. So if you really have a CHED phenotype, as was mentioned, it might be an intronic mutation. And if you have a family and it's a family of cousin marriage, it's very helpful to do homozygosity analysis to look at the regions that are homozygous, and that narrows it down. We've had patients that didn't come positive for SLC4A11. We did homozygosity analysis. It linked to the CHED gene, and then we looked in there, and there was an intronic variant. So in my experience, it's always SLC4A11, although there could be something else. Regarding I was very interested that you listed a few of I think one primary congenital glaucoma patient with a CPAMD8 mutation, another one with FOXC1. I think if we went back and look at those patients very, very carefully, you might find some iris abnormalities or posterior embryotoxin. This is not uncommon that some of these anterior segment dysgenesis genes that are typically associated with more obvious anterior segment dysgenesis sometimes present and they look like a primary congenital glaucoma, but it's really a different category. It's a secondary glaucoma. So we see that over and over again as we do more and more genetic testing. And the other one thing I'm going to say, I don't know how much time we have. I'll just make one more quick comment. Very nicely, we're talking about the artificial intelligence and distinguishing between congenital glaucoma, CHED, and Peters anomaly. But I would argue that congenital glaucoma is a diagnosis, congenital glaucoma is a diagnosis, CHED is a diagnosis, but Peters anomaly is really a description. I don't think it's really a diagnosis. And you showed many different genetic underpinnings for Peters anomaly, which goes with that. And sometimes it's not genetic. It's just something that interrupts that process. It can be environmental, which is a little bit different from the other two diseases, which we can say are diagnoses. I would consider Peters anomaly more of a description. Thank you very much. I don't want to take too much time.
Any other comments, questions? Nupur, anything on the chat box?
I have one question. Since, as the Dr. Radhika Tandon mentioned, that the ICD classification mainly based on the genetic information, but when we describe the disease, we first term or first line or first statement, we say that diagnosis is only clinical. So why don't we say that the diagnosis is clinical as well as genetic?
That's because we don't have the luxury of doing the genetic analysis of every patient. So we use the genetic information as our mental database, but not able to afford to do the genetic analysis for every patient. That's the reason you have to rely on your clinical judgment, and the genetic analysis should be done. But since it's not always possible, and again, it doesn't happen straight away. Even then, it takes some time for the report to come. So that is why in clinical terms, we say that the diagnosis is clinical, and we would like to encourage all the residents, students, and all clinicians to make a diagnosis, put a differential diagnosis, and then support it with the genetic information. And ideally, one should get the genetic analysis for all patients.
Thank you, ma'am. Also, Anshuman, there are distinct categories, category 1, 2, 3. Category 1, we have both clinical, histopathological, and genetic information. There are certain dystrophies we don't have. Their entirety is not understood, particularly genetic underpinning. So that's what, we label them as a category 1, 2, 3. Okay. Without further ado, we'll start with Professor Arif Khan. You can share your slides, sir.
Yes, let me do that. Yeah, you can see my screen?
Yes, we can see you're audible. Please go ahead, sir.
Okay. Thank you so much again for having me in this symposium and to allow me to speak about this particular topic, cornea plana, an underdiagnosed phenotype. Let me just see this, get this out of my way. Okay, here's an 8-year-old female with small eyes and high hyperopia. And from this viewpoint, it could be many, many different conditions. But when we come in with the slit lamp and we take a good look at this patient, and we see this relatively small cornea with the indistinct limbus, very flat. Look at that slit beam, it's like a table, and the rest of the eye is normal. This can only be one condition. It's pathognomonic for cornea plana, pathognomonic for biallelic Kara mutations. Cornea plana is a specific phenotype that is always due to biallelic Kara mutations. It's characterized by flat cornea, indistinct limbus, arcus lipoides, variable corneal opacity, variable iris abnormalities, often high hyperopia with refractive accommodative esotropia. These patients have normal axial lengths. Their hyperopia is from the flat cornea, and it's one of these conditions in ophthalmology where if you see the phenotype, you know what the gene is. Rarely we can see corneal decompensation, corneectasia in these cases. What I really would like to highlight is this condition is very under-recognized, and we as ophthalmologists should recognize it because if we don't diagnose it, nobody else is going to diagnose it. It's due to mutation in the gene Kara. And again, the features from a distance, the eyes look small, but you zoom in, you find those classic features. These patients often have esotropia, but it's usually refractive accommodative esotropia from the hyperopia. You give them the glasses, the eyes straighten. Here are the typical slit lamp findings. Again, look at that slit beam. It's like a table. It's so flat, indistinct limbus, eye otherwise normal. This is cornea plana. It can't be anything else. Another patient with some other findings. Sometimes they have horizontal ovalization of the cornea. Again, you see the indistinct limbus. Another feature they have is this variable corneal opacity, which is very interesting. Sometimes it's more apparent in diffuse illumination, not so apparent on the slit lamp exam. Sometimes these are misconstrued or misdiagnosed as being a visually significant corneal opacities, but in fact, it's very rare that they are. They typically are optically okay, although in diffuse light, they can look significant. Here's another patient with this corneal haze on diffuse illumination. It's not visually significant, but I'm not showing you this patient because of the cornea. I'm showing you because of the other eye, iris abnormalities. Sometimes they have abnormal irises with adhesions, and sometimes they're mistaken as Peters anomaly because of this. Rarely, this iris abnormality blocks the pupil and needs to be opened up. That's very uncommon, but rarely occurs, and when it does, it can easily be managed. Another uncommon feature, a less common feature of these patients is sometimes they get progressive thinning and astigmatism. Now, it's uncommon, but I would say it's common enough that I would consider it a rare feature, and sometimes it results in corneal hydrops, as occurred in this patient. Sometimes, again, another rare feature is corneal decompensation, endothelial decompensation, not only in adults, sometimes in children. It's rare, but it's common enough that I would consider it a rare feature of the phenotype. Now, what I'd really like to highlight to you, to the group today, is that cornea plana is under-recognized, often labeled as microcornea, microphthalmia, or Peters anomaly. And it's our job as ophthalmologists to diagnose this because, once again, nobody else is going to diagnose it if we don't. Here's an 8-year-old boy with a prior diagnosis of microphthalmia, but let me tell you, when we look at him at the slit lamp, it's classic cornea plana. He's positive for Kara mutations. Here's a boy diagnosed as microphthalmia with Peters anomaly, and that's because of these iris adhesions. But I think you recognize now that this is the classic cornea plana phenotype, and indeed, he has Kara mutations. It's not Peters anomaly. There's that flat cornea. Another patient diagnosed as microphthalmia with Peters anomaly, again, iris adhesions, some corneal opacity, but it's the classic cornea plana phenotype, and sure enough, Kara mutations again. This newborn was referred as Peter's anomaly, referred for surgery, and there is that corneal opacity that looks pretty bad in diffuse illumination, but actually optically it is not so bad. It's not so bad on the slit lamp. You look at his other eye, classic cornea plana. This eye is also classic cornea plana. Kara mutations. As he gets older, his vision is quite good with the refractive correction. He doesn't need a surgical intervention. Now, another thing I'd like to highlight is that we shouldn't throw around the term cornea plana loosely. We should only use the term cornea plana when we're talking about the specific phenotype that I'm describing that is from biallelic Kara mutations. So for example, in this girl who has unilateral microphthalmia and a small flat cornea, we shouldn't call that cornea cornea plana. That's not the cornea plana phenotype. The cornea plana phenotype is what I've been describing, and it's specific for Kara mutations. This is the first girl I showed you in the beginning of the presentation. When I first sent her for genetic testing for Kara, the mutation analysis came back normal, no Kara mutation. But I said, no, this is cornea plana, it has to be. And sure enough, when we did more extensive analysis, we found an intronic variant, homozygous in this girl. The phenotype is specific enough that the ophthalmologist can make the diagnosis and tell the genetic lab when they have to look harder. These are some of patients that have been diagnosed molecularly throughout the world. It's been shown all over the world now. We're seeing an increasing number of cases as more and more cases are being recognized. There's no phenotype-genotype correlation. In other words, any Kara mutation, whether homozygous or compound heterozygous, results in the features, and you can't correlate which features are going to happen by the type of mutation. Sometimes people can be confused because cornea plana can be associated with high myopia. Just like anyone can get high myopia. This is a boy diagnosed with anterior segment dysgenesis, but we look at his corneas, it's classic cornea plana, but there's no hyperopia. Why? He's got axial elongation. He just has axial elongation. He has high myopia, just like we see in the world, in addition to cornea plana, masking the high hyperopia. This woman came in with extreme pathological myopia, retinal detachment, and strabismus. But we look at the cornea, it's classic cornea plana, and sure enough, she has Kara mutations, even though her refraction is -18 and she has high myopia and retinal detachment. Again, don't let high myopia fool you. We can diagnose this condition from the anterior segment phenotype. Finally, one last thing I'll say that's a little bit confusing. Rarely, cornea plana can present as corneal ectasia. I mentioned before that corneal ectasia is a rare feature of cornea plana. Usually when I see it, it's after the diagnosis of cornea plana has already been made. But this boy came to me with progressive myopia from ectasia. I didn't know what he had, but his sibling was there. His younger sibling was there wearing glasses. I examined the sibling, and the sibling had classic cornea plana. Based on that, I tested both children for Kara, and sure enough, this 11-year-old boy with progressive myopia from ectasia has cornea plana, Kara mutations. Again, cornea ectasia is a rare presenting feature of this phenotype. So to summarize, I've gone through the phenotype of cornea plana. Please note it. It is very specific. It's specific for Kara mutations. We shouldn't misdiagnose it as microphthalmia or Peter's anomaly. We need to recognize this condition because if we don't diagnose it, no one else will. And one final plea that I will make, please don't use the word cornea plana loosely. Just use it when you're referring to this phenotype. Thank you very much.
Excellent, sir, for such a wonderful talk and covering every aspect of cornea plana. We have 88 families. 1/3 of them are autosomal recessive. Autosomal recessive has a mean K about 32, whereas a dominant 38. And as sir said, we did an age match control, so endothelial counts are significantly lesser in this particular population. And what I have documented is that corneal opacity tend to improve. The cornea gets much better as the time progresses. I don't have an explanation for that. But most of them, they're non-surgical. You don't need to do any keratoplasty in these cases. And as sir said, it is a specific entity, should not be, labeled any other conditions here. And as you rightly pointed out, in autosomal recessive variant, we see the significant iris changes. I've documented, Peters-like, features where iridocorneal adhesion. I think that cohort had a higher risk of glaucoma, much more than a 20%. Dr. Mandal also has operated a lot of these cases for a glaucoma. And few of them, I did a cataract surgery much later, at a sixth or a seventh decade. And of course, they have a suboptimal endothelial counts. And we do have about 11 families where they have a spontaneous corneal decompensation as well in this scenario. Dr. Meena also has done extensive work on a cornea plana. You have any points, Dr. Meena?
So just wanted to know, do we differentiate them as autosomal dominant and autosomal recessive? Because on KERA gene has been isolated only in the autosomal recessive.
As sir was pointing out, yes,
Yes,
it's a biallelic.
yeah.
So you would be able to do that thing,
So,
So do you want to throw some more information on that? How do we make
Well, I
it?
mean, autosomal dominant has been described, but there's never been a gene associated with it. It's not clear if it's, should be called the same thing or not. But the autosomal recessive form is so specific and is always from biallelic KERA mutations. As I mentioned in one patient, the KERA testing came back negative, but it was so clear it had to be. And then when we did retesting with an intronic variant was found. So this is just the power of the clinician. People sometimes say, why do we even need to examine the patient so carefully? We see something's wrong with the cornea, send it for genetic analysis. Who cares? We don't have to spend all this time to look at it. But actually, it's just the opposite. With the availability of genetic testing now and the ability to do whole genome sequencing and find all of these variants, you uncover things that you don't know what they mean, and they're meaningless unless you have a very, very precise clinical phenotype. So the need for good phenotyping and very careful exam is actually more in the era of genomic testing than before, because it's so confusing if you don't do that.
at what stage do we get glaucoma in these patients? Because I've been following a very young cohort, and I just want Dr. Mandal and you to tell me like the kind of glaucoma that I can expect in these patients.
Yeah, we've serially monitored these cases. As I said, 20% of our cohort had a glaucoma and needed a surgical intervention. It's very tricky even to measure IOP because one of the caveat is that, this cornea also microcornea many times.
So what did you see? Like it was an open angle, closed angle, trabecular dysgenesis? What kind, like did the corneal diameter increase?
No. So it is a basically intraocular pressure, and we have a disc changes because these children were more than 3 years at the time when we recognized them having a secondary glaucoma. I think it's a multiple mechanism. Dr. Mandal?
Yes, I agree. It's the question of comprehensive eye examination, and in suspected cases, probably more frequent follow-up is required to really identify development of glaucoma at the earliest possible stage.
Professor Tandon, any thoughts from your center? Because in South, we have a lot of parental consanguinity. That's one of the reasons I see a lot of autosomal recessive conditions. Prevalence is much higher. CHCD, we have, nearly 64% of our cohort. We have a little over 1,200 families, 64% from southern India, and 12% is only from the northern rest of the, India. Similarly, when it comes to cornea plana, you have any observations?
I would like to say that I really learned a lot from Professor Arif's talk, and those anterior iris adhesions that he was showing in 2 patients, those little filiform and then like a blotch on the cornea. Recently, we had I'd seen a patient who had actually been diagnosed as ICE. So it's, And I
Yeah,
really let it look different from ICE, and I have to go back to that consultant and say, get the biallelic mutation done. So it's an ever-changing world, and it's really important to have the proper phenotypes. You have to have the photograph, you have to have all the clinical information, and there's a lot that can be gained from such meticulous knowledge. But answering Meenakshi's question, I think you should always look out for glaucoma. There's no simple answer to that, and because you never know what's going to happen. So that's, and then as it happens, then you treat it accordingly.
yeah.
Can I
Similarly,
just say two things? Okay, go ahead.
go ahead, sir, please.
No, I just want to say that certainly glaucoma can happen, but in children, I find it quite uncommon in the cornea plana patients. I think it's as they get older, at least in young children. And the other thing, these iris adhesions that are sometimes misconstrued as Peter's anomaly or something else. The thing is, in Peter's anomaly, the iris adhesions tend to be more central, and these are not central. So, I mean, this is something that can be seen clinically. And ice syndrome, I've never seen an ice syndrome in a child. I don't know how old that patient you
No,
were
that patient was
discussing.
older. The patient was older.
Okay.
Yeah, but then these children are going to become older, and then
Yes,
they're
yeah.
mistaken as ICE. So I have to go back and see about that one.
Yeah, true, madam. I agree with you. It is not uncommon, both axonal rigor and even a cornea plana sometime, labeled as eyes. Bilateral eyes is, I have never seen in my 20 years practice. So they referred, and as you rightly said, we further explore and give a right diagnosis and yeah, manage them. Agree with you.
One last question or a comment. I think this is one congenital anomaly where systemic associations are by far very rare. So
Correct.
has anybody seen any systemic associations, or because I don't know if I have missed, just any comments please on that?
Well, this is part of the beauty of having a specific diagnosis and knowing the gene. We know that there's no systemic association at all. So KERA mutations only affect the cornea. So that's one of the advantages of having a molecular diagnosis, because you can rule in or rule out those genes that can be associated with non-ocular findings.
Thank you.
And as I said, it is a non-surgical diagnosis. Most of them, they need a good cycloplasic refraction. So the hyperopia may range between 8 to 14 diopters. Sometimes some of these cases, when you take a picture, they're so hyperopic, you can see the optic disc as well. So we'll move on with the next topic.
But don't be fooled, because sometimes they're myopic because they just have axial myopia just as a
Absolutely.
coincidence.
Absolutely. Absolutely. Yes. Dr. Meena, we'll get started your talk. Thank you. Very interesting discussion.
Can I continue?
Yes, please.
Yes.
We can see
So-
your slides. You're audible.
Yeah, only my video is not very good. It's very shady. So good evening, everybody, for everybody staying back on a Sunday evening. Thank you so much. And I'll be sharing a few inputs on dermoids, about its clinical presentation, pathogenesis, some of the classifications which are existent in literature, and the varied managements that are done. There's no single said management for these. Few complications and differential diagnosis and few advances. So by definition, it is a mature element, a choristoma, a benign lesion, which is not, present in a site which is not supposed to be of its nature. So, but its tissue is a mature tissue, it's not immature, and the formation of malignancy is very, very rare. So by histology, both the ectodermal and mesodermal elements are present. The ectodermal elements being the stratified squamous keratinized or non-keratinized epithelium with the hair follicle and sebaceous glands. The mesoderm elements being the blood vessel, adipose tissue, and smooth muscles. So predominantly, both the ectoderm and the mesoderm will be given in the histopathology of any limbal dermoid. Pathologically, they are classified as 4 types: the dermoid, which we have just now described, with the ectoderm and the mesoderm. The lipodermoid tends to have more lipomatous tissue or the adipose tissue with very minimal ectodermal tissue. And there's something which is known as complex choristoma, which is more and more getting to be known now, where there is, along with the mesoderm, there is more amount of neural tissue, smooth muscle tissue, and lacrimal gland tissue present here. The epibulbar osseous choristoma is very specific. They're seen as a bony lesion somewhere between the superior and the lateral rectus muscle, so typically at the superior bulbar conjunctiva. So the limbal dermoids are the second most common dermoids other than the dermolipoma, which is seen in the lateral fornix. There are no specific mutations that I have come across with dermoids, but Chinese group has presented a ring dermoid, which is associated with a PITX2 mutation. And we all know that PITX2 mutations are associated with other anterior segment anomalies. In the world, it is present as incidence in 1 in 10,000. So commonly these patients present to us with children being brought to us by parents, typically with a problem of cosmesis being the problem. At that time at which these patients present, the parents do not know much that there is a visual abnormality. It's only later when we do the refraction and measure the visual acuity, they come to know that the visual acuity is also low. So generally, they do not come for visual acuity, they come for a cosmetic reason. And the number of reasons for decreased vision is because of astigmatism or a very large dermoid extending into the visual axis, and all this causing amblyopia. Some of these have very prominent hair protruding because they have ectodermal tissue here, causing foreign body sensation. And because of its elevation, they can cause tear film abnormalities, leading to Dellen at the edge of the dermoid. And if they have been operated elsewhere and there has been extensive handling of the subtenon region, there could be additions to the muzzle leading to diplopia, and very large dermoids can actually impair the closure of the eyelids. Most commonly, to make it more obvious, and that's why they present very commonly to us cosmetically, is they present in the infratemporal area. So they're visible just as they open the eye. The second most common area is just under the lid, which is supratemporally. Associations, the most common association worldwide is associated with a syndrome known as the golden hour syndrome, which is the oculo-auricular vertebral dysgenesis. They have upper eyelid coloboma, they can have preauricular tags, vertebral anomalies, and commonly with single or multiple epibulbar dermoids. The other associations which could be life-threatening and could have multiple association, neural, cutaneous, and osseous, are the Delman syndrome, the ring dermoid, which I mentioned, the mandibulofacial dysostosis of Franceschetti, and epidermal nevus syndrome. And some of these, there are anecdotal reports where if you find morning glory disc, they could be associated with dermoid in the anterior segment. And very rarely they could be life-threatening. They could have multiple cause of decrease in vision, and there could be severe anterior segment dysgenesis, including cataract, microphthalmia, and congenital aphakia. This is a patient of mine which was presented with a feature of somebody mentioned as sclerocornea, but as you can see along the limbus, you can see flat dermoids in both the eyes, which appear to me like the ring dermoid mentioned by the Chinese group, although the patient's parents did not want to do any genetic evaluation. So the pathogenesis are not one, but it is commonly thought to be due to a metaplastic transformation of the mesoblastic tissue existing between the optic nerve and the surface ectoderm. There could be a PITX2 mutation, as already mentioned, or there could be the embryonic stem cells, germ cells, which are carried by the circulation into the orbit, giving rise to these dermoids, or there is a faulty migration of the pluripotent stem cells during embryogenesis. Stem cells have been hypothesized as one of the causations of forming faulty stem cells have been known to be a causation in the pathogenesis of limbal dermoid. Man's classification is still very good. It's a very simple classification where the stage 1 dermoid, which is 5 millimeter in diameter and which has a very superficial involvement. And majority of these patients come to us for cosmesis and can be treated with conservative management or shave extraction. If it's deeper and it's going up to the Descemet's membrane but not perforating the Descemet's membrane, it's stage 2. And in stage 3, the entire cornea is replaced by a dermoid, which needs extensive surgery. There has been a paper in 2018 in the Cornea by the Chinese group with a new grading system where they not only try to evaluate the dermoid in its extensibility, but also in the location and the surface morphology. And they help to prognosticate based on points to which they give given to the each parameter. So anything which is got a grade of more than 6 and 9 have a poor prognosis because of the extensive location and area of involvement even into the conjunctiva. So pre-operative planning, we of course do all the investigations which is meant to be done in a child prior to surgery. But one of the important investigations that sometimes needs to be done to see the depth of the limbal dermoid, to see if it is extending beyond the angle, is to see the ultrasound biomicroscopy. Generally, since our lesions although tend to involve very deeply, if we decide not to go in and remove the entire dermoid, then probably this can also be skipped. But for the sake of documentation, if it is going very deep, then the prognosis also could be very poor. So the indications for grade 1 dermoid for any intervention will be the child which is rubbing the eye and causing amblyopia, or there is a Dellen which is noticed by the parents, or any aesthetic complication, then there is a need for intervention in the grade 1 dermoid. So the usual management in the grade 1 dermoid is to give glasses and to give amblyopia therapy. We can do shave excision, and this shave excision can sometimes leave a scar. Over the area of shave excision, we can place amniotic membrane. Certain groups have also given mitomycin C to prevent pseudopterygia. If you are doing a deeper excision, you need to supplement that area with a tissue. This is usually a lamellar keratoplasty or a sclerokeratoplasty. And a deeper lesions, generally you need to do a penetrating keratoplasty. So the main caveat in treatment of these patients are a simple excision where there is not much loss of volume in the cornea. We do a simple excision, but it is always better to cover the area for better reepithelialization with an amniotic membrane. When the depth of the lesion is very deep and there is a chance of decrease in where a chance of thinning is there and volume replacement is needed, either either a corneal tissue or a scleral tissue or a pericardial tissue or Tenon's tissue have all been mentioned with an amniotic membrane graft. Grade 3, we have already mentioned that it carries a very poor prognosis. A total anterior segment reconstruction should be done. I do not have any experience on this. So this is how a limbal dermoid is seen. It's operated, measured. This is a patient where a lamellar keratoplasty was done, where bare dissection with just a crescent blade. So when you do shave excision, sometimes they can be just showing you how the post-operative thing. So there should be some talk to these parents about the realistic expectations that some amount of scar and whitening. But what I have seen is this whitening tissue generally tends to reduce over a period of time. So this is first, the conjunctival area is removed with a Westcott scissors, and a shave excision is done with the help of crescent blade. The bleeders are cauterized both under the dermoid and over the sclera. Then we go ahead with careful dissection of the corneal tissue. In fact, I had a perforation at one point, and where I seal it with a fibrin glue. You make a pocket on the corneal side so that the cornea sits well and you are able to do the thing. So there was a area of perforation, and I proceeded after putting the fibrin glue. I still continued debulking the cornea. The idea is to have a thin desmoids, the thin area of the bed, so that there is less vascularization. The thicker the bed, then there is tends to be more vascularization and lipid over the area of the bed. So when you measure it and then you take the peripheral part of a donor cornea, you remove the desmoids membrane and you place it over it, and suture, you mark just a hand fashioned, and mark the area as to how much I need. And 10-0 nylon is just enough to secure the area, and I used a fibrin glue to reposit the conjunctiva. So data from our own hospital shows that there was more male preponderance, and our most common method of treatment was shave excision with amniotic membrane graft, or sometimes with conjunctival autograft. Very rarely lamellal keratoplasty or penetrating keratoplasty was done. The complications that we have faced and seen in the literature are all per-op or post-operative, per-op microperforation, and post-operatively like infections, opacification of the graft, underlying haze, vascularization of the graft, interface neovascularization, all being one that they reduce the cosmesis. Very rarely graft rejection because there is a stromal tissue there. And of course, because if these are children, steroid-induced glaucoma is a problem. And scleral thinning because of a lot of, if you go and debride a lot of the scleral component of the dermoid, that area could be left thin. So this is a patient where the lamella keratoplasty was done, but there was interface vascularization and needed a regraft. So it's important to know that there is a decrease in the vision of these patients preoperatively, and whatever age you do the surgery, the postoperative amblyopia tends to be a challenge. And there are conflicting reports. Yes, surgery has to be attempted, but there is no promise to the patient that vision will improve. A very good amblyopia therapy and a very adherent protocol to this should be discussed to the parent, and that visual cosmesis is not the only goal of the surgery. So earlier the surgery, the better outcome only if amblyopia therapy is adhered to. Caution should be exercised in certain patients who have golden hour syndrome, because these patients tend to have congenital corneal anesthesia, and they could be leading to poor epithelialization after the surgery. There tends to be astigmatism in these patients, and this astigmatism usually flattening in the area of the dermoid. Differential diagnoses are mentioned many. These could be keloid, osteomas, ectopic lacrimal gland, and any of the other things which a physician is not very likely to be aware about could be thought about. So some of the things that I've read in the literature was to prevent the pseudopterygia formation. You could use mitomycin C if you're doing it along with conjunctival autograft. Instead of, if there is a paucity of scleral graft or corneal graft, there is a chance, if you are working in a multi-specialty hospital, to procure a pericardial graft, because pericardial graft can also be a bit thinner compared to that of a scleral graft. Fibrin sealant have been used instead of sutures to put the corneoscleral graft in place. And there could, to improve the cosmesis, people have done tattooing, but generally tattooing so far has been left to those patients which are non-seeing eyes. But yes, to improve the cosmesis, tattooing has been done. Limbal stem cell transplantation has also been done with the notion that these are limbal stem cell deficiency patients. And sutureless amniotic membrane has been also tried. And a very rare report that I read was there was a metastatic cholangiocarcinoma in the donor eye because of from the donor eye spread to the patient who received it. So these are some of the patients with limbal dermoid, with peripheral lipodermoid, with, you can see the typical facies of the golden hour syndrome. Thank you so much.
Thank you, Dr. Meena, for a very informative lecture. Yeah, you can stop sharing your slides. Yeah, as Dr. Meena said, there are close to 26 syndromes associated with the dermoid. And as she agreed, this is sometimes it's mainly a cosmetic outcome which are giving. So we have to be very guarded about visual prognosis. Post-surgery, interestingly, most of them have astigmatism actually get accentuated when you do a lamellar surgery. I typically use, the DSEC precap. Are there any questions? Dr. Revati, you have any questions for Dr. Meena?
I have a question if nobody has.
Yeah, please go ahead, sir, please.
How often do people just do simple debulking, not going to get the whole thing out and just to, because that's very helpful to many of these patients, especially if you don't have the tissue available. I feel that people always feel like they need to get the whole thing out, but I don't think that's necessary in certain situations. So what do you think about that?
Yeah,
Yes,
absolutely. The
Doctor.
size of the dermoid is less than 1/5. So as you rightly said, just a simple debulking is good enough. Sometimes we also do a conjunctival autograft or a slit. Dr. Meena, your point, please.
Yeah, I agree. In 2003-4, when we started operating on them, the thought was to remove the entire dermoid to make the area of excision as bare as possible. But then we realized that we are removing a lot of normal tissue, and now we only remove the dermoid flush with the cornea and do a conjunctival autograft to prevent any kind of pseudopterygium formation. We agree that yes, there is no need to, unless it is extremely large, more than covering 2/3 of the cornea, where removing only the tissue will still be cosmetically looking visible. So to reduce the complications also, not doing extensive surgery also has reduced the complications and follow-up of these patients.
I would like to make a comment, sir.
Yeah, please.
So, as Dr. Susan Jacob has mentioned in her paper, that we need to do a very superficial dissection. So, we don't need to take out the entire white thing. We just need to do the superficial dissection, because if we do the deeper dissection, especially in the limbal girdle region, so that will lead to a post-operative ectasia, and that will lead to further worsening of the astigmatism. So, just doing a simple shave excision and then applying some tattoo dye along with smile lenticule and suturing it up gives a wonderful cosmetic outcome as well as a astigmatic outcome. So that can be definitely tried. So a very superficial dissection is what is actually advised.
Yeah,
Absolutely.
but her patients were all very small dermoid, doctor. I've seen that paper. But if it is very large, you still have to go a little deeper, and there I think you need to do you have to augment the cornea, which will prevent all the ectasia and all that.
Right. Yeah. Thank you. So I get started with my presentation. So I'll be talking on a selective endotheliectomy in a Peters anomaly. We innovated at LV Prasad Eye Institute. I do not have any proprietary commercial interest.
As we all know, Peters anomaly is the most common anterior segment developmental abnormality, presents with central or paracentral corneal opacification. It accounts for nearly 50% of the children born with corneal opacity. Bilaterality is seen in 2/3 of the cases. Incidentally, it is also one of the most common indications for a corneal transplantation among congenital corneal opacity. This is a typical case of type 1 Peters anomaly with a posterior excavation, which is evident on an anterior segment OCT as well. In this particular instance, wider zone of cornea is involved. On UVM, you could actually see the perimeter of the corneal opacity having a synovial attachment, which is clearly evident on horizontal and vertical scans of the UVM. This is the typical case of keratoirodolenticular dysgenesis, where right and left eye of the same child, where left eye has a severe involvement with the cataract. While conservative approach applied in a milder variant of Peters anomaly, where surgical interventions are typically resolved in a severe cases of Peters anomaly, often have an abysmally poor outcome. While small subset of milder Peters anomaly tend to spontaneously recover over a time, but majority may not show a discernible clearing owing to presence of anomalous layer as shown in this particular slide. Histopathologically, the posterior defect filled with a uveal tissue and anomalous fetal membrane, as evidence in these histological slides. Perhaps this particular layer inhibits the normal endothelial migration, thereby preventing the spontaneous recovery. Based on our clinical as well as histopathological observation, we felt there is a focal area of anomalous Descemet's endothelial complex underlying the posterior defect, which perhaps serve as a contact inhibition. Once we remove those anomalous layer, the perilesional healthy endothelium tend to regenerate and fill the denuded area, lead to the resolution of the corneal edema. And also robust scar remodeling in children together with overlying well-preserved anterior stromal architecture helps in the rehabilitative journey of a child. We documented the postoperative healing response after SEPA using high-resolution anterior segment OCT. At 1 month postoperative follow-up, DM is not only well opposed, the endothelium was covering the defect, which is sharply demarcated. Together, clinically, we could actually perceive stroma is much more compact and transparent postoperatively. Based on the location and extent of the corneal opacification, the corneal opacity can be categorized into the zone 1, which is the central island of corneal opacification within central 6 millimeter. Zone 2, central cornea where the peripheral cornea is involved. Zone 3A is a near total corneal opacification. Zone 3B, complete corneal opacification. This is a technique demonstrating selective endotheliectomy. Step 1, severing the communication between iris and cornea. Step 2, identifying the actual defect. Third step, delicately removing the anomalous corneal endothelium without disturbing the integrity of Descemet's membrane. Step 4, checking the integrity of Descemet's membrane. There was no Descemet detachment at the end of surgery. Type 2 Peters anomaly, wherein additional lens aspiration along with sphincterotomy was considered in view of a large corneal opacity. The sequential picture collage of a milder variant of Peters anomaly, right and left eye of the same child, showing the postoperative corneal edema resolution with the scar remodeling as observed over 18 months period. The sequential picture collage of severe Peter anomaly, top and bottom row showing a significant improvement in eyes with a smaller zone of corneal involvement compared to the middle 2 rows where corneal opacity is much larger along with a cataractous lens and a suboptimal outcome with a secondary glaucoma. Meaning even in a type 2 Peters abnormality with a smaller zone of corneal involvement can help achieve a good outcome.
So we did for a variety of cases where we could...
Primarily our cohort included type 1 abnormality. Median age at surgery was 7.2 months and 85% had a discernible corneal clearance. So the 97% had ambulatory vision and BCVA significantly improved owing to the resolution of the corneal opacification. On careful evaluation for the factors responsible for a SEPA failure, we found that one is severity of the disease, the zone of involvement, and additional intervention seems to be the important risk factor for the non-resolution of the corneal edema. 85% of the mild to moderate cases had a significant corneal clearing in comparison to the severe disease. The cornea tend to clear even beyond 12 months. So perhaps this may be related to the remodeling ability of the younger children. Over the last 3 decades, the literature primarily focused on anatomical success has shown a modest outcome, and only 20 to 60% of them achieved a 2400 or a better vision at a median follow-up of 4 years. The current study where most cases have actually showed a significant improvement and vision is continued to improve over a period of time. Our study validates the long-term outcome of SEPA. It's a novel, less invasive surgical strategy for the treatment of penis. In 85% of the cases, opacity is significantly cleared with a marked improvement in the visual function. We've also demonstrated to the best of our knowledge for the first time that SEPA can be used even in the cases with the severe form of keratolenticular adhesion as long as the central corneal opacity no more than 7 millimeter, or at least half of the peripheral cornea has remained clear.
Yeah, based on our experience, we devised a novel clinical algorithm wherein milder cases can be managed with conservatively, meaning, opacity, which is less than 3 to 4 millimeter, just need a good refraction, sometimes, dilating drops. Moderate are the excellent candidate for the SEPA. In a severe cases, in addition to the SEPA, I may have to do a, partial iridectomy. And if there is a lens involved, lensectomy.
The findings of our study questions the prevailing paradigm whether this procedure could be offered as a preferred surgical modality in every case of fetal anomaly, or only in a select cases where corneal opacity less than 7 millimeter, irrespective of the type of fetus anomaly. The long-term results are extremely promising, can be a very effective surgical alternative to penetrating keratoplasty. And this would benefit hundreds of children with fetus anomaly-related corneal blindness worldwide.
Meaning, based on our data, only severe cases would need something like a corneal transplantation. As I showed my algorithm, we mild to moderate cases can be easily managed. And it is a one-time single surgical intervention. Of course, we are not promising them a 6/6 vision, but most cases do have, you can mitigate all complications related to the keratoplasty, and even any trained pediatric or, pediatric specialist, who's good in, pediatric cataract surgeries can do this surgery, so that we can reach, the large population, since this is one of the most common abnormality worldwide. If there are any questions, I'll be happy to answer. Yeah, go ahead, sir, please.
It's a fantastic technique and it's very appealing. But, sometimes you have adhesion to the posterior cornea from the iris causing an opacity, and you just break that adhesion and there can be some corneal clearing. So how much of the effect might be from that versus the removal of the endothelium itself?
That's a great question. Actually, some of these cases, how did we learn? By serendipity. I used to, do before keratoplasty, used to do a syneculisis, give a couple of weeks before you go for a transplantation. I observed, some of these cases start clearing. And you're right, because at the perimeter of the corneal opacity where you have a numerous iris stands, so even breaking them, so that perhaps, facilitate the, the endothelial migration. So this procedure, technically, biologically, we are promoting the endothelial healing or acceleration. We are just removing that impediment or anomalous thing, which is impeding the normal endothelialization. I agree with you. Even at times, a simple syneculisis will do the trick. So yeah, we'll take a questions as we move along. I'll just start with the first case from Dr. Mandal.
A drop of viscoelastic material was placed in the opening of the Slem's canal. 2 tying forceps were used to grasp the illuminated microcatheter, placing the tip in alignment with the canal, and the device was advanced into the canal. The lighted tube allowed for the surgeon to visualize the cannulation of Slem's canal for 360 degrees as the catheter was advanced. The catheter was grasped with a forceps when it emerged from the distal end of the canal and was pulled out a little bit. Both the exposed ends of the catheter were pulled in opposite directions using a tangential force like a purse string, thus garroting all 360 degrees of the trabecular meshwork. With the help of venous scissors, the 2 by 2 millimeter trabeculectomy block was removed and an iridectomy was then made. A subconjunctival injection of 0.3 ml of dexamethasone was given in the inferior fornix. A poorly functioning distal outflow pathway will necessitate an additional surgical step that bypasses it, like trabeculectomy. This surgical procedure actually represents a microcatheter-assisted, novel, distinctly advanced, luminous technique that is Mondal technique suitable for advanced primary congenital glaucoma. This technique may represent the next step in the search for the best surgical treatment for management of advanced primary congenital glaucoma.
All right. Murli, can I comment for a minute?
Yes, sir, please.
Yes, this particular technique where microcatheter assisted 360-degree trabeculotomy was done, and at the end of that procedure also trabeculectomy part added. This particular technique is specifically reserved for very advanced stage of neonatal onset congenital glaucoma, where corneal diameter is very enlarged. And in addition to isolated trabeculodysgenesis, which is the hallmark for primary congenital glaucoma, in the advanced stages, there may be associated abnormality in the post-canalicular outflow channel, like the collector channels, the aqueous veins, etc. And that's the reason I feel that in small subset of very advanced stage of neonatal onset glaucoma, there is need for adding trabeculectomy even if you are doing 360-degree trabeculotomy. That's the argument. This is a very advanced stage of the disease. In the milder form, only trabeculotomy may be sufficient, or 360-degree trabeculotomy may be sufficient. That's the comment.
Thank you, sir.
Any question?
Nupur, can you just load Parul's video before? Yeah, if there are any questions to Dr. Mandal, sir. Thank you, sir. It's a very innovative and a nice technique. Reliably, we can
Thank you.
explore the entire trabecular meshwork. You have something, normally it is a blind technique.
Yeah. So microcatheter helps because you can monitor the passage of the microcatheter through the Slem's canal. Misdirection is avoided.
We'll take a few more questions at the end. We'll get started with Dr. Parul's talk, please.
Okay.
Dr. Parul, just keep telling me to change the slide, okay?
Yeah, can you make it full text?
Yes. Yeah.
Yeah. So today I'll be presenting navigating shield ulcers in VKC. Next. So the aim of the presentation is to discuss the clinical features and management of shield ulcers. So we had a 15 years old male who complained of redness, foreign body sensation, watering in the right eye since 1 month, and episodes of redness, itching and watering in both eyes since the past 5 to 6 years. He had history of rubbing of both eyes. The symptoms exacerbated during the change in season. He had history of itchy skin rashes over the joints. No history of asthma, no history of family history of allergy. So this was the anterior segment photograph of the right eye. On a version of the upper eyelid, we could see these giant papillae. And in the background, you can also see a shield ulcer that is covering the superior 1/3 of the cornea. Next slide. So on a close-up evaluation, this was a shield ulcer and it had all the debris attached to it. This was a grade 3 shield ulcer. We scraped it just to make sure that it was not infective. It was, the culture was sterile. There was no KOH gram stain positive. Next slide. So this was a grade 3 shield ulcer. I'll come to the staging. This was the left eye. The left eye had a similar picture on the eyelid, that is giant cobblestone papillae, but the cornea was clear. So these are the grades of papillae given by Bonini et al. Grade 0 is no papillae, grade 1 is less than 0.3, grade 2 is 0.3 to 1, then 1 to 3 and more than 3. This is the Cameron grading of the shield ulcer. So we had a grade 3 shield ulcer, which was an elevated plaque above surrounding epithelium along with inflammatory deposits on it. So if we have a transparent clear base, it is grade 1. If we have a translucent base, it is grade 2. But this was opaque, so this was grade 3. Next. So this was the grading in our patient. So our patient had a grade 3 severe VKC. This was also given, this grading system was also given by Bonini for VKC, and a grade 4 very severe VKC. Next slide. So right eye had grade 4 and grade 3 shield ulcer, and left eye had grade 3 VKC without any shield ulcer. So what are the management strategies? We can do a simple debridement and put a bandage contact lens over it, or we can do debridement and put amniotic membrane over it, or we can do a excimer laser phototherapeutic keratectomy. So medical management is usually done in grade 1 and surgical with AMT or BCL after debriding for grade 2 and 3. So this is a paper by the LV Prasad group. They also said the same thing, that 95% of the grade 1 ulcers can be managed medically, and grade 2 and grade 3 require debridement with AMT or BCL. So what was the treatment plan in our case? We counsel the patient, we check the compliance of the patient, and we should tell the patient to avoid environmental allergens in cases of VKC. Avoid rubbing, that is very important because it can lead to, VKC can further lead to keratoconus. Next. So this was the step ladder pattern of treatment of VKC, as we all know. Next. So what we gave we gave a tablet Visalon 30 mg, that is 0.5 mg per kg of body weight, antihistaminic, eye drops moxidexa, CMC, olopatadine with ketorolac, cyclosporin drops, and tacrolimus HS, and HPMC ointment. And then we did a shield ulcer debridement in the right eye, along with corneal scraping and bandage contact lens application, along with supratarsal triamcinolone, that is 20 mg, 0.5 ml in each eye. So we did a BCL instead of a AMT. So with AMT, we realized that sometimes the AMT, it undergoes epithelial to mesenchymal transition. So it gets integrated into the epithelial defect and it leaves the opacity behind. And as we will see in the post-op pictures, next slide, the the shield ulcer cleared up beautifully and there was hardly any opacity seen. So we also got some blood investigations, that is absolute eosinophilic count, which was normal. Vitamin D level was deficient, so we advised the patient to take vitamin D. So vitamin D is also associated with VKC as well as keratoconus. The serum Ig was raised, for which we sent the patient to the pediatrics department, and the allergy panel report was positive, though not to a particular specific antigen, but it was positive. So this was a post-op day 1 photograph of the right eye of the patient. You can see the shield ulcer absolutely cleared even on first post-operative day, and the BCL was beautifully settled on the cornea, and the vision was 612. And we shifted the patient to loteprednol 4 times a day, and the rest we continued the same treatment. Next. This was the post-op 1 week photograph. You can see that the very faint opacity was there. With the BCL, we had removed at 4-5 days interval post-op, and the UCVA had improved to 6-9. And even the papillae had decreased in size. Next slide. This was the left eye. The papillae had significantly decreased in size and the cornea was clear as before. Thank you so much.
Yeah, thank you, Parul, for that excellent, surgical debridement. Yeah, I agree with you. Just simple BCL insertion with a debridement actually, that's a way to, manage.
Yes, sir.
Dr. Radhika, any pointer, any experience of, secondary infection in these settings?
Secondary infection can happen, of course. So one need to always counsel the parents that there is an epithelial defect, so avoid getting tap water in the eye, maintain hygiene, and also mention that there is a contact lens because otherwise they may miss the follow-up and sometimes come back with an infection related to that.
Absolutely. One of the pointer, Parul, when we examine if there are any anterior chamber cells or inflammation, so that's a marker of infection. So even after debridement until I get the culture report. Shalini,
Yes.
can we load your presentation? Are there any other questions to Dr. Parul?
Dr. Muralidhar, can I ask a question?
Yeah, madam. Yeah, please.
Yeah, she mentioned about the supratarsal triamcinolone and given in both eyes at the same time. Would you like to take any precaution before that? Because this is a depot therapy. If the
Yes.
child is going to be a steroid respondent. So
Yes.
it's advisable either first give Decadron and see whether there is a steroid response and then go for triamcinolone, or you
Yes.
give it one eye at a time so that you can be sure instead of giving in both eyes. But
Both
it's
eyes.
a very good treatment for shield ulcer.
Yes.
Great point, madam. In the last 12 years, I've not done a single supratarsal injection. I'm wary of this depot, ever since we have a tacrolimus, even this gate papilla just melt like that. We don't use any supratarsal injections. You're right. We had glaucoma, we had fungal infections. One child I remember from Calcutta where I have to excise the conjunctival depot to control intraocular pressure. Absolutely.
Can I ask you, Murli, are you using the skin preparation of the tacrolimus or are you using an ophthalmic preparation?
In India, we have both available.
Both.
So 0.03 is an ophthalmic preparation and 0.1 is a skin. And even, externally over the eyelid skin application is sufficient. We don't have to put it into the cul-de-sac. We just tell the parents, at night applications, just over the eyelid, if they can smear it, it'll absorb, and we have seen a remarkable results.
Remarkable.
Shalini?
Yes, sir. I'm just trying 1 second, sir.
Oh yeah, sure. Take your own time.
Till then, so do you want to take up a question that was on YouTube, YouTube, by Dr. Ramya? How do you differentiate between microphthalmos, microcornea, and cornea plana? So if you can.
Dr. Arif, do you want to answer this one? There was a question, how do you distinguish microcornea, microphthalmos, and cornea plana?
Yeah, well, cornea plana is a very specific phenotype where the cornea is a little bit smaller, but a lot of it is this indistinct limbus. It's really not that small, and the cornea is extremely flat. And the other features that I discussed before about the variable corneal opacity, various iris adhesions. Microcornea is a small cornea. I think the official definition is 10 millimeters or less. And it's otherwise, normal. And usually in cornea plana, the corneas are not so small. They're not usually less than 10 millimeters. So if I saw cornea less than 10 millimeters, I wouldn't be thinking of cornea plana. Microphthalmia, of course, the whole eye is small, and often it is associated with other ocular abnormalities. So those are the distinguishing features.
Also, one more question, similar case scenario, if they have a central corneal haze, if the pachymetry is unreliable, that's what the question was. And, if the eye care shows, the IOP is borderline or elevated. So how do you proceed such cases? That was a question in the YouTube.
Yeah, that's $1 million question. We see a lot of patients with CHED who get misdiagnosed as glaucoma, Not all patients with CHED have falsely elevated intraocular pressure, but some of them do. So you really have to use judgment. You have to use other parameters such as axial length, corneal size, if you can refract them, But I'm glad that point was mentioned because we have to take into account whether or not the intraocular pressure measurement is accurate in a child. Sometimes there's a corneal abnormality, and just because the cornea pressure measures high, we shouldn't jump to the diagnosis of glaucoma. We should have other supporting evidence.
Great. Yeah. Shalini, get started, please.
Good evening, everybody. Today I'll be presenting two interesting cases of therapeutic keratoplasty, which was done in a pediatric age group. And the first case is a 2-month-old baby who was brought to the OPD by the parents on 25th of May with the complaints of whitish discoloration of the right eye for the past 2 days. The child had a fever 2 days back. The parents give a history of applying castor oil and coconut oil in the right eye on and off whenever the child was having redness. On general examination, the child was thin-built and there was no signs of pallor and icterus. He was the second child of a non-consanguineous marriage with a normal antenatal history, and it was a full-term LSCS delivery. And the birth weight was 2.3 kg, and he was immunized up to the age. On ocular examination with the torchlight, the lid of the right eye showed a mucopurulent discharge, the conjunctiva showed diffuse congestion, and there was a hazy cornea. And the rest of the anterior segment details was not clear. And the left eye was normal. And the B scan of the both eyes showed a normal study, and the right eye congenital sphere was done, which showed a free of gram-negative bacilli on gram stain. A differential diagnosis of right eye bacterial keratitis while chemical keratitis was made, and the child was advised admission and was started on 5% cefatoxime drops once in 5 minutes for 30 minutes, followed by once in 15 minutes for 1 hour, and then half an hourly till night, and 2% abicacin drops once in 5 minutes for 30 minutes and once in 15 minutes for 1 hour, and then half an hourly till night, and homemade eye drops 3 times a day. The parents were clearly explained about the condition of the eye and possibility of corneal melt perforation and may require therapeutic keratoplasty if the condition worsens. The child was also referred to the pediatrician to rule out septicemia. The child had no clinical signs of systemic infection and was started on oral moxiclav drops as prophylaxis by the pediatrician. The child was admitted and was closely monitored. The ring infiltrate was increasing and became a subtotal corneal infiltrate with central thinning. And the B scan also showed optic nerve head edema with increased choroidal thickness. Explained to the parents that the child would require TKP. Unfortunately, I don't have the video for TKP. The child underwent therapeutic keratoplasty under general anesthesia on 31st of May 2024. A 9.5 mm host cornea was marked and 10 mm donor cornea was prepared, and 8 interpreted nylon sutures and 8 continuous micro sutures were put for the button, and 2 peripheral iridotomies were done, and the lens was clear, and anterior chamber was found at the end of the surgery. Post-operatively, the child was treated with Vigamox eye drops 1 hourly, Ocubol DX drops 4 times a day, and Pantogel eye ointment 3 times a day, and syrup omnocortal 2.5 ml BD was given for 5 days. The child was discharged after 2 days. And the child came for review on the post-operative day 10, and the corneal button showed the growth of Pseudomonas aeruginosa. On clinical examination, the right eye showed reduced lid edema, mild congestion, the graph remained clear and looks well opposed, and the B scan showed mild RCS thickening with the vitreous was clear. And the drops, Vigamox was tapered to 6 times. The child was advised to continue Ocubol DX 4 times and Pantogel 3 times a day. The child came for regular follow-up, and antibiotics were stopped in 2 weeks' time and maintained only on topical steroids and lubricants. The child came for a follow-up review of 1 month post-op, and examination anesthesia was done on 28/6/2024. As you see in the picture, the right eye graft remained clear, the AC was well formed, the pupil was pharmacologically dilated, and the lens was clear, and there were sutures in situ with the grooved graft-post junction scarring, and all the sutures were removed at 1 month post-operatively, and the IOP was 8 millimeters of mercury, and the fundus IO was normal. The left eye was also normal. The child was given Ocubol DX drops 4 times a day and Pantogel ointment 3 times a day. On 45 days post-op, the child was at this time was 4 months old. The right eye graft remained clear and there was no sutures and the eye was quiet, and there was no resistance on occluding the left eye. The pediatric ophthalmologist's opinion was taken for right eye visual rehabilitation, and they had suggested to patch left eye 1 hour per day for 1 month, and best corrected visual glasses were given for the right eye. And the patient was shifted to Predford eye drops 3 times a day, Pantogel eye ointment 3 times a day, and Talimus LS was started on 45 days post-operatively. and the patient came for a regular follow-up. And this is the picture which was taken 100 days post-op, which is 12th September 2024. The right eye graft remained clear, limbal pigmentation can be seen, and the lens was clear, the anterior chamber was quiet. The child is fixing well with right eye when left eye was occluded. The child was using glasses regularly and advised to continue patching. The B scan was done. The axial length was approximately 20 millimeters in both the eye, and the child was on regular follow-up and tapered steroids and maintained on Predford eye drops once daily. The child came on 25th November 2024 with the history of right eye ACCO, and the left eye was absolutely normal. At this time, the child was shifted from Predford to Toba DM eye drops 3 times and CMC eye drops 4 times a day. On 3rd December, the ACCO resolved and was the child shifted to low tibet eye drops BD and CMC drops. This was the recent picture of the child who came to his review on 8th December 2024, which was 6 months post TKP. The right eye graft remained clear, the eye is quiet, and limbal pigmentation. As you see in the picture, the child is orthophoric and the child has a good cosmesis and anatomically and functionally visual outcome with the keratoplasty. And the Predford was stopped at this time, and the child was maintained only on Talamus LS once daily. Coming to the second case was a 4 days old baby who was referred from Kerala with a history of left eye anterior staphyloma since birth and the iris coloboma to a hospital on 4th November 2022. The child was the third child of a non-consanguineous marriage with a normal delivery with a normal antenatal history and the birth weight of 3.3 kg. On ocular examination, the torchlight, the right.
You can just, summarize, right? We are running short of time.
Left eye showed a retractile anterior staphyloma. As you see in the picture, left eye is a picture of the child. Left eye with a large anterior staphyloma with the lids retracted. And the child was referred to a neurologist and was started injection cefotaxime. And the child underwent therapeutic keratoplasty on 16th November 2022. As you see in the picture, the child had a large necrotic cornea. The limbus was well demarcated. There was no scleral involvement. After dissecting the cornea, there was dense exudates in the anterior chamber, which we removed with the vitrectomy machine, and there is dense exudates in the pupillary area also. After clearing the pupillary area, the lens auto-expelled, and so we had to remove the lens also, and the anterior vitrectomy was done. The limbal margins were cleared, and hand-fashion donor button was prepared, and it was attached to the host cornea with the interrupted tenonylon sutures, and the anterior chamber was found at the end of the surgery. And the post-operatively, the baby was treated with ocupol DX drops and Pandagel ointment, and the corneal button showed the growth of Staph aureus, and the pediatrician advised to start syrup, amoxicillin, and paracetamol. The baby came for regular follow-up as it was a large graft and it was done only as a salvage procedure. It eventually failed. Now the child is 2 years old. The right eye is normal with the inferior iris coloboma with a normal fundus. The left eye eventually went to the thysis bulbi.
Great outcome. Thank you, Shalini. I think, we'll ask Rashmi to load a presentation. Rashmi, can you put your slide? Nupur, do we have any grace time? We have to stop at...
We need to stop at, after 8 minutes, we'll need to give it to the other.
Oh, yeah, sure.
Yeah.
Hello. Yeah, someone has to unshare it now.
Dr. Shalini, can you unshare your screen, please?
There is some problem.
Sunil, can you unshare it here?
Done, ma'am.
Yes.
Yeah, the first case, very good outcome. We do have a similar outcome in a keratoplasty, in a neonatal infection particularly. Pseudomonas is one of the very common. And luckily in your case, it's not a multi-resistant.
Yes, sir.
Yeah, so Rashmi, you can get started, Rashmi.
Yeah, thank you. Good evening, everyone. I'll present an interesting case of congenital keloid. Yeah, so we have a 2-month-old infant who was brought to our clinic by parents who had noticed a whitish opacity in both the eyes. Soon after birth, it was not non-progressive, not associated with any redness, watering, or previous trauma. The antenatal history and past history was uneventful. Nutritionally, child was on mother's milk. There was no history of any parental consanguinity. General examination revealed a healthy-appearing baby with age-appropriate weight and height. On torchlight examination, both the eyes had showed a leukomatous corneal opacity with vascularization. Rest of the anterior and the posterior segment details were not appreciated. For further detailed evaluation, child was planned for examination under anesthesia. This is a clinical picture of the right eye taken under EUA. What we can see here is there is a protuberant, buff-tinged, fleshy mass with a smooth glistening surface and vascularization covering almost whole of the cornea, and the limbus is also ill-defined. There is no view of rest of the anterior chamber and fundus. This is the clinical picture of the left eye, which is in similar lines as in the right eye. So B-scan ultrasonography was done, which showed the presence of lens echoes and a normal posterior segment in both the eyes. UBM study showed thickened cornea with variable echogenicity. Iris stump was visible in the periphery and the angle anatomy was poorly defined. So based on this, we made a diagnosis of both eye primary congenital corneal opacity, and the differentials here were congenital corneal keloid and dermoid. Now, how do we differentiate both of them? Dermoids are the usually yellow-white, elevated vascularized lesion, mostly seen at the inferotemporal limbus. They also have mesenchymal appendages, and they usually unilateral. Whereas keloid is chalky white, gelatinous, glistening lesion, which may or may not have vascularization. They're usually corneal. They don't have any mesenchymal appendages, and they're usually bilateral. So we planned a full thickness optical penetrating keratoplasty with a permanent lateral paramedian tarsorrhaphy, initially in the right eye, then followed by in the left. We used the optical grade tissue. This is a surgical video which shows the corneal diameters are being measured. This is a suction refine of 8.5 mm that is being used for partial host trephination. Once the partial trephination was done, we went ahead and did a layer by layer removal. This is the anterior layer, the middle layer, and then finally the posterior. So intra of what we observed was there was 360-degree aniridia, but there was presence of a clear lens. 9 mm optical grade donor corneal graft was sutured over the host bed using 16 interrupted 10 monofilament sutures, and finally a lateral paramedian tarsorrhaphy was done. Post-op, the patient had an uneventful course. Patient was kept on topical steroids, topical lubricants, antibiotics. The excised tissue was then subjected to histopathological examination, which showed the anterior lamella showed there was thick keratinized epithelium with keratin flakes and keratohyalin granules. The basal cell layer of epithelium was identified with mild pigmentation, and there was an absence of Bowman's layer. The middle portion of this anterior lamella showed blood vessel with thick hyalinized collagen bundles and activated fibroblast. The middle portion, the mid lamella showed thick hyalinized bundles with blood vessels, and as in the posterior lamella, there was absence of the DM endothelium complex. So what is a textbook description of corneal keloids? Epithelial hyperplasia, parakeratosis, keratinization. The Bowman's layer may be disrupted or absent. And in the stroma, there will be irregularly arranged fibroblasts, collagen bundles, and vascular channels, along with activated fibroblasts and myofibroblast. So dermoid on histopathology actually shows keratinized epithelium with rete pegs, the openings of the hair follicles, irregularly arranged thick hyalinized collagen bundles, along with adnexal structures like sweat glands, pilosebaceous unit, and fat globules. So this is the follow-up examination under anesthesia. Both the grafts were doing well. The patient was kept on topical steroids, lubricants, antibiotics, and oral immunosuppression as well. So as we all know, keloids are rare entities. It was first described in 1865 by Smith et al. Most commonly seen in first and
sum it up in a minute. Yeah.
So etiology, the congenital one is usually because of failure of normal differentiation of corneal tissue during embryogenesis, and the systemic associations which we have to look out for is Rubinstein type B and Loeys syndrome. So there are two parts to this: removing the existing lesion and preventing recurrence. For removing, various modalities that have been used is superficial lamellar keratectomy, dark PK or sclerokeratoplasty. And in order to prevent recurrence, various entities which have been used in literature is steroids, cyclosporine, cryotherapy, laser, and AMG with superficial keratectomy. So the take-home message is it's a rare entity, and careful examination has to be done to rule out any systemic associations. Among all modalities, a full thickness PK has least chances of recurrence. Thank you.
Thank you, Dr. Rashmi, for sharing such a unusual case scenario. Are there any questions? I thank all speakers and panelists for the contribution. I greatly enjoyed, and thank you, Nupur, and also All India Ophthalmic Society and Dr. Honavo for this opportunity. If there are any questions, the 2 minutes we can.
Is aniridia commonly associated with this condition? Because aniridia we know associated with LSCD.
Correct. So as she said, it is a congenital variant, madam. Now we have a primary, secondary, and a congenital. In a congenital, it is a mesenchymal disorder. Our paper is coming up. We made a new classification and histopathological markers as well. So they can usually associate it with the syndromes.
Do you have any genetics for those cases, Morley?
Yes, yeah, we have a genetic analysis.
But I guess I have to wait for the publication to hear.
Yes.
We have 1 minute left. So there was one more question on the YouTube by Dr. SK. What is the difference between corneal haze and corneal edema? So one of you could quickly.
Yeah, the corneal edema is basically, endothelial insult. It may be transient, whereas haze or opacity, it is a permanent. It may not reduce. And it may have a different level. Corneal haze may be anterior or posterior, depending on etiology. And you have an indentation technique. If you use one of the metal object and indent, put a pressure on the corneal surface, cornea, if it is edema, cornea tend to clear. So these are all certain ways by which we can differentiate. And are any last minute questions? I really thank all of you for on a Sunday being here and contributing to our education program.
So before we move on, we'll take a quick photo as well. So yes. Mr. Sunil, can you do it for us, or I'll take it?
You will have to do it.
Okay, so I'll just, everybody can look at the screen. Yeah, start.
Yeah. Thank you, Dr. Arif, and thank you, Meena and Dr. Radhika and Dr. Revati. Yeah, appreciate your contribution. Thank you so much. Bye-bye.
Thank you, Dr.
Thank you,
Morley.
everyone. Thank you.
Thank you, sir.
Thank you.
Thank you, Nupur.
Thank you.
Thank you. So we hand over the session. Tushar, you're there, right? Yeah.